So we are starting, ma'am. So a very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. So the topic for today's webinar is endometriosis and everlasting challenge. So I would like to welcome all the participants and request them to post their queries in the comment box so that we can have a short Q&A session at the end of the presentation. And now it's time to introduce our invited speaker for the day. We have Dr. Sai Lakshmi Diana ma'am with us. Madam has completed her MBBS in MSCOG and Madam is currently the senior consultant in gynecological oncology, Apollo Cancer Institutes, Apollo Hospitals, Hyderabad. Madam was graduated from Osmania Medical University, Hyderabad, and MRCOG from University of Manchester, UK. Madam is currently the cancer surgeon with more than 18 years of experience and a trained expert in performing open laparoscopic and robotic procedures for gynecological cancers. She is also trained gynecologist with 20 years of experience and an expert in dealing with menstrual problems, pelvic pains, and menopause issues. She is adherent about promoting women's health and well-being. She has shown a keen interest in making women awareness about cancers. So with this introduction, I welcome you, ma'am, and I'm handing the session to you, ma'am.
Thank you. Thank you so much. I want to start sharing my screen. Just a quick word with the audience. I have a power cut at home at this moment of time, and I'm running this on my mobile data. So I hope there won't be any issues because of that. And if the power comes back at some stage, I might have to switch back to the normal power. Can you see the screen?
Yes, ma'am.
Can you see the PowerPoint?
Yeah, ma'am, we can see.
Okay.
Well, you can just maximize the slide, ma'am.
I'll do that. Yeah. Well, the audience can see that there are 73 slides in this presentation, but please don't worry, I won't keep it going on forever because you'll soon discover that how many of our slides we talk about endometriosis, it continues to remain a challenge. And I, by profession, I'm an oncologist, but as you know, in India, you don't just stop with one subspecialty. Even if you write your sick, tell people you're an oncologist, a patient who wants to come to you with endometriosis will still come to you and will still insist she wants treatment with you. And I'm sure you have such patients where they insist they want you as their doctor. So you end up treating their endometriosis, you end up getting all sorts of benign gynae problems, even if you're an oncologist. And that is a situation with me. I mainly operate on endometriosis cases just because my other gynecology colleagues would like another person when they are operating on endometriosis cases. So majority of the times my role in endometriosis is actually to operate on women who have stage 4 endometriosis. That is where I get involved. I usually am not involved in the initial management of endometriosis. But obviously, you end up reading a bit about it. And because of the talk, I started reading more about endometriosis out of inquisitiveness, thinking, okay, let's see what's latest about it. Let's see how things have changed. Has anything more recent come up with endometriosis? And it's surprising where we were 20 years ago and where we are now and where we will be in 10 years' time. I'll come to that gradually. For those of you, the younger generation gynecologists who are listening to this talk and who yet have to give a lot of their postgraduate exams in future, a little bit introduction about what endometriosis is. We all know that endometriosis is ectopic endometrial tissue. One thing, if there is one thing that you want to remember about endometriosis, which will make a difference to how you manage the moment a patient with endometriosis walks into your clinic and you're thinking, what do I do to her? If you can remember one thing, and that is this condition is estrogen dependent. The day this woman stops having estrogen, or we all get estrogen from ovaries, we all get estrogen from body fat. The estrogen that comes from body fat cannot be very much regulated by the gynecologist, but the day you know her ovarian estrogen supply is depleted, you are winning over this endometriosis. So every time you're planning treatment for these women, remember that this is an estrogen dependent condition. And one thing many people have often said that cancer is better than endometriosis, or endometriosis is worse than cancer. Because even with cancer patients, sometimes you get that confidence that, yes, I have cured this woman. Give me a stage one cancer of the uterus, cervix, or ovary, and I can confidently tell you I can cure that woman. But give me a woman with stage one endometriosis. Can I say that about them? No. This is one benign condition which actually invades normal tissues. This power of invasion, where does endometriosis get this propensity to invade? And that is what is making life hell for these patients, that this condition can actually invade. It's a benign condition and it invades other tissues. No other benign condition actually has got this invasive potential. It depends on estrogen and it can invade. These are the two things which make life difficult about endometriosis. Some other fact, 6 to 10% of women have it. If 10% of women have it, then every 10 of us should have endometriosis. I'm sure there is at least 50 gynecologists sat listening to this talk today. So, do 5 of us have endometriosis? That tells us that there's a lot of endometriosis which we don't know about. Maybe we have it and we don't know. Only when you start diagnosing people, or only when you start doing laparoscopies or laparotomies for other reason and you detect endometriosis, you get to know that it's actually a pretty common condition. Every 10th woman has it. But if you talk about infertile women, obviously a lot of them have endometriosis. And if you talk about women who have chronic pelvic pain, then even a lot more, almost all of them have endometriosis. So, endometriosis is mainly seen in women with pelvic pain and in infertile women, but also women in general tend to have a lot of endometriosis. It's important to know how to classify endometriosis. It's important to sound scientific all the time. When you're describing a patient of endometriosis, when you're giving them a discharge summary, or when you're writing it notes, it's always better to stick to scientific terminology. And one of the ways to classify endometriosis is superficial or peritoneal endometriosis. Are there ovarian endometriomas? And is there any deep infiltrating endometriosis? If you look at a good scan report from a very good radiologist, they always talk about DIE and also about ovarian endometriomas. The superficial peritoneal endometriosis, neither you can palpate nor the radiologist can actually see it. That is only something you can make out at laparoscopy. And where does the superficial peritoneal endometriosis happen? It happens in the dependent portion of the pelvis. If you look at this diagram, this is a very good diagram which shows superficial peritoneal endometriosis. So the endometrial tissue, if it is coming out of the fallopian tubes, that's what we think happens, then it drops onto the other pelvic organs. So there is some on the ovaries, some on the superior vesicle fold of peritoneum, some in the pouch, some along the surface of the rectum, and so on. And talking about, the dependent portion of the pelvis is where you see the superficial endometriosis. And obviously you can't palpate, it's too superficial, and therefore the radiologist will not pick it up either. Talking about ovarian endometriomas, we have all been in situations where we have seen endometriomas, we have dealt with them. And any one of you who has tried to operate on a woman with endometriomas know that this ovary will not lift up. The ovary which you can see now, if you want to lift it up and if you want to say excise or do whatever you were planning to do for endometrioma, you realize that that ovary is properly stuck to the parametrium and into the pouch of Douglas. Typically, it is stuck behind the uterus. So the sticking happens on the anti-mesenteric border and it won't just lift off for you to nicely operate on that ovary. It's very stuck. And you know, the moment it is stuck and you want to peel it off, the organ that you're worried about that lies right under that ovary where it is stuck is the ureter. And the characteristic features are it is adherent on the antimesenteric surface. It's stuck to the posterior peritoneum. The cyst wall is yellow and the contents are chocolate colored. Sometimes the cyst wall can look properly brown because of the hemosiderin pigmentation. This cross-section imagination is important because you see how close the intraovarian vessels are to this cyst wall and how well circumscribed this cyst is. This becomes important because when you want to treat this endometriosis, you want to excise that cyst wall, otherwise the woman will recur. The deep infiltrating endometriosis can be palpated, can be seen on imaging, and the depth of invasion is usually more than 5 millimeters, and the invasion is usually into the uterosacral ligaments, and this is where they can catch the ureter. And and usually when you do a per rectal examination, you can feel this nodule anteriorly, and the patient will wince when you touch it. It's quite a characteristic symptom. And there's another way of classifying endometriosis. One is a pelvic endometriosis. Is it just in the pelvis? And if it is in the pelvis, then where? Is it in a gynecological site but not in the pelvis? Then that would be the vagina, vulva, and the cervix. Why cervix is not a part of the pelvis, I don't know. Maybe they mean it's in the pelvic floor, but the non-gynecological sites, or probably actually it is the extra pelvic site. You know, you're below the pelvic diaphragm. You're looking at it from down below. Maybe that's why. And then the non-gynecological sites, where else can you have endometriosis? It can be in the bowel, it can be in the lungs, it can be on the skin in the surgical scars that we often see in the, not often, but sometimes see in the cesarean scars. I've never known lymph nodes to be involved with endometriosis, but this is increasingly being described that when you have pelvic endometriosis, you see endometriosis in the pelvic lymph nodes as well. Personally, when we operate on pelvic endometriomas, we don't go around doing lymphadenectomy. So I'm not actually experienced in taking lymph nodes, or actually don't see the point in taking lymph nodes in women with pelvic endometriosis, but it is known to go into the lymph glands. If at all you see a complex cyst on the ovary and the radiologist has raised a question mark, is this complex cyst because of neoplasia, or is it complex because of endometriosis? And if in that scenario you're doing a lymphadenectomy, maybe you will see endometriosis in those lymph nodes. And apparently endometriosis can happen in the brain as well. And we all have known about the ectopic transplantation, the presence of endometrial tissue outside the uterus, and we think it's retrograde menstruation, which probably does that. The coelomic metaplasia theory has also been in vogue for a while. We have heard that the tissue in the pelvic peritoneum undergoes metaplasia. But then there's something called induction theory. I didn't know what the induction theory was, so I read up, and apparently it's unknown substances released from the shed endometrium. They cause changes into the mesenchyma, which then becomes endometriotic tissue. And this is also interesting that there is a genetic risk of endometriosis. And now so much of future in endometriosis talks about gene therapy. They want to do gene therapy. They want to find the defective part of the gene which causes endometriosis. And in fact, it is known what the defective part of the gene is. So if you repair the gene, then obviously the gene therapy will work for endometriosis. From our point of view, from the current generation point of view, if we know that endometriosis is genetic, then we can focus on the siblings of patients with bad endometriosis. If they have symptoms, then we know that probably it is endometriosis. And we all know the clinical presentation. In fact, we gynecologists are very aware of the dysmenorrhea associated with endometriosis. In fact, that's what makes women come to us, especially the congestive dysmenorrhea, and then the deep dyspareunia too, chronic pelvic pain, ovulation pain, perimenstrual pain, infertility. To be honest, I've never suspected endometriosis in a woman who comes with chronic fatigue, because almost every woman who comes to me is complaining of chronic fatigue. I haven't ever come across a woman who doesn't say she's tired and feeling weak. So to suspect endometriosis in every woman with fatigue is probably a bit of an overdiagnosis. But if someone has other symptoms and also complains of fatigue, then maybe you could suspect. And pain during defecation. And as we all know, usually none of us immediately jump to the fact that this woman has endometriosis the moment they complain of any of these. It's only when the pain is persistent and not responding to simple measures that we start to think this could be endometriosis. And often there is a delay in diagnosis. and dysmenorrhea and pain. What is the cause of dysmenorrhea in women with endometriosis? Well, anybody who has done a laparoscopy for endometriosis and see how badly the uterus and the ovaries and other pelvic organs are adherent to each other will make you understand why these women are in so much pain. And there is also inflammation, there is redness, there is swelling, and the deeply infiltrative endometriosis typically presses on the uterosacral nerves, giving a lot of backache, sciatica, coccydynia, and then the adhesions, and then the fibrous plaques of endometriosis, and then all the blood that stays behind and becomes a collection. And why does it cause infertility? Well, we know that endometriosis causes endometriomas. It blocks the tubes, it makes the tubes have adhesions. And obviously, with a tube which is fixed and adherent, and with an ovary which is full of endometriomas, there's going to be no oocyte, there's going to be no oocyte pickup. The whole environment is very hostile. Even if you look at it, it makes you think, oh my God, I don't want to look at this pelvis. It looks too red and angry. Imagine an oocyte and a sperm trying to become an embryo in that environment. It's not going to happen. And there's another way of classification of endometriosis, and I urge any of you who is doing a laparoscopy for endometriosis to please use a staging chart. There is a score out of 40, and this score will help you decide if the woman falls into minimal, mild, moderate, and severe. Mainly because it's like when we give a cancer diagnosis, we are very clear what stage, what grade, what treatment, etc., because that never changes, and this cancer diagnosis has an implication for life. So it's very important to say stage 1B1, grade 3 type, whatever. So in the same similar way, this endometriosis diagnosis will remain with this woman forever. It will have a lot of future implications. It will mean a lot more treatment in future. You're never going to cure an endometriosis patient. She's going to be your patient or someone else's patient for a very long time. And in future, this could be a woman with infertility. And then they would like to know how bad her endometriosis was when you did your operation. So always print out a staging form like this, which clearly will make you figure out what her score is. It's very easy to fill this chart and put them into a stage category, and take lots of pictures, take lots of videos during your operation, so the patient can have an evidence to show, or a fallback option when some other surgeon or some other doctor or you yourself want to look at her previous disease in future. A little bit about thoracic endometriosis. This gained a lot of popularity during the pandemic time. I don't know, I've heard a lot of people talk about the endometriosis in the lungs, maybe because during Corona times we did a lot of lung imaging. We never actually we very rarely do CT scans in young ladies because you don't want the radiation to their breasts, to the heart, and to the lungs. So one of the age group which we never like to do a CT scan is children and young ladies. And unfortunately, in the pandemic, a lot of young ladies got chest imaging. You know, some people went for a CT scan chest even without prescriptions. They just would go and get a CT chest. You know, for them, it was one way of finding out, do they have corona? Is it better? Is it worse? Have they got rid of it, etc.? A lot of innocent people unknowingly went for CT scans, but that gave us an opportunity to look at a lot of CT scans of younger population, and a lot of endometriotic type lesions were seen, and these women also gave a history of coughing up blood, breathlessness, etc. And that's when a lot of focus has been laid on thoracic endometriosis. Apparently it is the most frequent extra pelvic location of endometriosis. I thought the rectum and bladder were the most common locations, but obviously they come under the pelvis, the rectum and the bladder. If someone asked me where I thought most endometriosis occurred extra pelvic, I wouldn't have thought of lungs, but apparently it is. There is a lot of endometriosis happening in the lungs. In 10% of women with endometriosis, you apparently see thoracic endometriosis. And these women could present with pneumothorax, hemothorax, hemoptysis, and chest pain. Sounds a bit scary, to think a woman on a monthly basis will have any of those symptoms. And the word catamenial means it happens on a cyclical basis associated with periods. So if a woman cyclically on a monthly basis has these chest symptoms, then you say they have catamenial thoracic endometriosis. What do you do about this? I don't think you do anything different to what you do for pelvic endometriosis, but it's always nice to know why any of your gynecological endometriosis patients might have chest symptoms. How do you diagnose? We're going back to pelvic endometriosis. How do you diagnose it? Well, obviously, pelvic tenderness. That is what the woman comes with, deep dyspareunia, dysmenorrhea. And when you examine, you notice that the woman is tender. Uterus is often retroverted and fixed, almost often. PR reveals tender uterosacral ligaments. And then if there is an endometrioma, obviously you will feel an adnexal mass. And apparently, the detection is improved if you do the examination during menstruation. Obviously, we try and avoid pelvic examination during menstruation. And please do, if you suspect endometriosis, please do a PR examination. Sometimes you get more information that way than with a VE. And how do you diagnose it? How often can you clinically diagnose endometriosis? Well, not often. You can suspect endometriosis. And if you suspect mild endometriosis, the scan's not going to show you those superficial patches. If you really suspect endometriosis, then do a laparoscopy. That's a gold standard investigation. And again, there is a guideline which clearly says that, say you suspect endometriosis, you see a young woman with symptoms, you suspect endometriosis, and you put her on COCP, or you put her on NSAIDs, usually, or you put her on progestogens. In which case, when you start them on treatment, don't do your laparoscopy. Don't say, okay, start the COCP. And whilst you are on COCP, in the next 4 to 6 weeks, we'll plan a laparoscopy. Do not do it that way, because if it is very superficial endometriosis, you might miss the diagnosis because a woman is on treatment. So if you're doing a diagnostic laparoscopy for endometriosis, let the patient not be on treatment. And obviously, we all do suspect, and that is our clinical diagnosis. And imaging, what kind of imaging would you do? Understandably, an ultrasound scan is the best way to image women, especially a transvaginal scan. But if ultrasound scan reveals large endometriomas or is suspecting deeply infiltrative endometriosis, then do go for an MRI scan. Go for an MRI scan if you're going to operate on the woman. If, say, for example, you want to diagnose endometriosis, you've asked for an ultrasound scan, and then ultrasound scan shows a lot of endometriosis, but you feel uncomfortable doing a stage 4 endometriosis and you want to send her to a higher center, or you want to refer her to somebody who specializes in endometriosis, then don't ask for an MRI scan then and there, because that woman might then undergo another MRI scan after she reaches a center a few months later. Or the people in the center who you sent referred her to might not want to operate on her straight away. It's always best to do an MRI scan very few days before surgery, so you get a very accurate picture. In fact, when we do rectal endometriosis cases, we have the MRI pictures in the theater right in front of us, because we often look at the scan and decide how deep we need to go into the excision of the uterosacral ligaments and how much to shave off on the rectum and so on. So do an MRI if you're going to do surgical treatment. Otherwise, do the transvaginal ultrasound scan, and the MRI can be done preoperatively. We get a lot of reports which say hemorrhagic cyst, endometriosis cannot be ruled out. And this often happens when either the radiologist is inexperienced or the endometrioma is small. It's hard to tell the difference, but experienced radiologists usually are good at telling you, because the endometriomas have a typical ground glass appearance, which the hemorrhagic cysts don't. And transvaginal scan obviously is any day better than an abdominal scan, unless the woman is a virgin. And ovarian endometrioma gives a ground glass appearance. And some people, in fact, a lot of radiologists again tell you that complex ovarian cyst, endometrioma, query neoplasia. How on earth will a gynecologist who's going to touch you and feel the patient, tell the difference between a neoplastic and an endometrioma just on clinical examination for clinical correlation. What's clinical correlation when I'm asking you to tell me on a scan if it looks neoplastic or if it looks endometrioma? So that is a role of the radiologist to tell us the difference, not say that it could be either and for the clinician to correlate it clinically. It makes a hell of a lot of a difference how I treat a woman with endometrioma versus how I treat a woman with cancer. You know, with the cancer, you never go laparoscopic and cut open the cyst wall. You never rupture the cyst. You never cause peritoneal spillage. While with endometrioma, you never want to do an open surgery. This woman has a lot of future ahead, and you don't want to give big, big scars. So it is a role of a radiologist to tell us, is it complex? Is it endometrioma? Is it neoplasia? Is it endometrioma? Is it a hemorrhagic cyst? If your radiologist in his or her report is not able to tell this, then please refer this patient to a radiologist who specializes in gynecology. There is plenty in the city of Hyderabad. Outside Hyderabad, I won't be able to tell you who the gynae good radiologists are, but go find out who they are, discuss with your colleagues, and let a radiologist clearly tell you what they think it is. It's not that their word is gold standard at the end of the day, but you need that clarity before you treat a woman with endometriosis. You need to know, is it endometriosis, is it cancer, or is it a hemorrhagic cyst? Of course, you can do a diagnostic laparoscopy. How many times on diagnostic laparoscopy you went and you still are not sure it could be a borderline ovarian tumor or endometriosis? You made a hole in the ovary thinking it's endometrioma, and then a papillary type of tumor comes out and you think, goodness me, I made a mistake here. You don't want to be making those mistakes because a patient pays the price. This is a typical ground glass appearance of an endometrioma. MRI, get an MRI done, but like previously mentioned, please do it like literally 1 or 2 days before your surgery so you can plan your surgery properly. If you think the woman has DIE going into the rectum, or there is ureteric involvement, or there is bladder involvement, always do an MRI before surgery. Don't just go confidently, because either you end up taking less endometriosis out or you might end up having a lot of complications. Would you, it's a question to the audience, how many of you, when you suspect endometriosis, do a CA125? And the answer should be 0%, because CA125 is not a test you do for endometriosis. CA125 should not be done for endometriosis. If a woman has a cyst and it's been called complex cyst, and the radiologist said do a CA125 correlation, then a lot of people get CA125 done, and often it is high and you still don't know what it is. A high CA125 could be a neoplastic cyst, a high CA125 could be endometriosis. I've seen endometriomas with CA125s reaching 1500, 1700, even 2200. How do you tell the difference? So CA125 is not of any use when you're doing endometriosis cases, but it is of use for follow-up. If, say, the CA125 is high before you excise the endometriomas, and knowing these people recur, it's always good, like a cancer tumor marker follow-up, CA125 could be a follow-up marker. But upfront, should you do it? And the answer is no. Principles of treatment. Why do you treat endometriosis and how do you treat? And well, treatment is if the woman is symptomatic, and you treat them because they are in pain, you treat them because they need fertility, and you treat them because you want to improve the quality of their life. You want them to live without pelvic pain, you want them to live without deep dyspareunia, you don't want them to have chronic pelvic pain or backache or sciatica. You want them to be able to pass a motion without being in too much pain. And treatment will be in the form of tablets, treatment could be in the form of surgery, or treatment could be a combination. Treatment could be in the form of medication, which is not necessarily in the form of tablets. It could be injections or intrauterine implants. Uh, what do you do? I've only highlighted something in red to which I wanted to bring your attention. What do you do for asymptomatic women with minimal endometriosis? Then how do you know they have endometriosis if they are asymptomatic? Maybe a coincidental finding during a laparoscopy for other reasons you notice, or you don't, cesarean, usually pregnancy, you don't see it. For whatever reason, you found out she has endometriosis. she's asymptomatic, don't do anything. If this woman is yet to become fertile, tell her that she has a condition which could increase the risk of infertility. So we only treat symptomatic cases. And Dr. Someshwar, who works for Shield Company, did this slide for me. And it's a very beautiful slide which puts all the options here. But then, if you go down the list, you think, wow, there is so much option available for treatment of endometriosis. And then, if I asked you, if I said, please, can you cross off that medication which we don't use anymore, or can you cross off that which probably is not very useful? Is there anything which you people would cross off from this list? Obviously, he got this list from guidelines and from various other college websites where they give you treatment options for endometriosis. Go down the list and tell me, if you were the treating physician, treating gynecologist, is there anything here which you would cross off? I initially thought, other than COX2 inhibitors, I won't cross off much. But then, as you keep going down, as you keep thinking, and as you keep writing down, you realize that there's a lot of this we don't actually use anymore. Okay, GnRH analogs. I don't know why I jumped to that, but let's talk about it. GnRH analogs, any of you use GnRH analogs? I do. I use a lot of GnRH analogs for endometriosis patients. If there's a lot of endometriosis, then I use it pre-surgery. If there's a lot of endometriosis left behind post-surgery, then I use it too. So yes, GnRH analogs are used, and it's not something I'll cross off. The first thing we use is NSAIDs. We give simple painkillers, meftal ibuprofen apparently works extremely well for endometriosis pain. And then COCP. I'm extremely fond of COCP for endometriosis. I run back to back 3 packets and then give a break after every third packet. And usually, most people find a relief with that. It doesn't cure the endometriosis, it doesn't make their lesions disappear, but it's some relief to this woman to have only 4 or 5 menstrual periods per year rather than 12. Talking about GnRH analogs, we all know that they cause menopause like symptoms. And but I normally don't give it for more than 6 months, mainly because of the cost. Unfortunately, GnRH is expensive in India, and cost is one thing which restricts me. If cost wasn't a restriction, and if you wanted to give back HRT, you can give GnRH analogs for nearly 2 years. Aromatase inhibitors, if you think, look at it, there are SERMs in this list of medication, and would you give an aromatase inhibitors? Would you give it? Actually, aromatase inhibitor on its own doesn't have a big role to play in endometriosis. So that's something you would cross off. And then SERMs like raloxifene, would you give that? And again, the Cochrane database says there is no big role for SERMs. What about progesterone receptor modulators? The progesterone receptor modulators are mifepristone and ulipristal. Ulipristal is given a lot for fibroid uteruses. Mifepristone is given for termination of pregnancy. But other than that, I don't see a gynecologist regularly, routinely, confidently, comfortably prescribing mifepristone or ulipristal for endometriosis. If there is any of you out there who has a lot of experience with these drugs and confidence and comfort, please do tell us, because personally, I don't do these drugs for endometriosis. And if you do and if it works, it would be lovely to know that, so even we can learn and we can start using them. So again, now you go back to the list. Why are COX2 inhibitors crossed off? At one time point, COX2 inhibitors were very popular painkillers, but the NICE guidelines said about 4 5 years ago that COX2 inhibitors increase the risk of heart attacks and strokes. And this drug, COX2 inhibitors, are now banned in most developed countries. So COX2 inhibitors are not even available these days. So there's no point even talking about it. NSAIDs, mefenamic acid, ibuprofen, we all use. COCP, we all use a lot. Progestogens, the recent progestogens are very much in demand, and in fact, it's become the most popular drug for endometriosis at this moment of time. GnRH agonists, we have always been using leuprolide, Zoladex, etc. But the cost and the menopause side effects are a problem. And then the selective progesterone receptor modulators, which is discussed. are again not very popular. First line treatment remains COCP because it's one of the safest. You can easily use it in young people. And one of the best things about COCP is the price. You want this woman to take it for years together. You're telling them there is no cure. They might have to take it for a very long time. And then you put them on something very expensive. They're not going to persevere. Even if they want to, some people can't. The good thing about COCP, which has been told by ACOG, RCOG, NICE guidelines, ESHRE guidelines, everyone says the same thing. COCP is a first line modality of treatment. Thankfully, at subsidized prices in India, COCP work fantastic for endometriosis. They're good for initial stages where you want to control the pain. They're good for maintenance therapy after you have done your definitive treatment. And the added advantage of providing contraception and also decreasing the future risk of cancer. But then, if this patient of yours actually wants to be fertile, then you're stuck. COCP is not your method of choice. But then, what is? That is a problem. There's nothing much else you can do which provides fertility and which also controls endometriosis. So, of the options we have, COCP is a good option. Not the triphasic pill where you take 62 tablets in a row where there is different level of estrogen and progesterone every day. The triphasic pill is good for acne. In fact, that is the only clinical reason you would want to give somebody a triphasic pill. What we are talking about is tricycling, where there is no difference in the dose of estrogen and progesterone every day. You just give the same dose day after day after day after day for 62 days, and then the woman takes a 1 week break. And in that 1 week, she could obviously use any painkillers if the period gets unbearably painful. And then we all know that progestins are Dynagest, that has become extremely popular, progesterone for endometriosis. Progestons can be taken orally. Progestons can be inserted implants. The Norplant and the Depo-Provera injection are very common methods of contraception in the developed countries. In India, we are not so familiar with the 3 monthly injection or the Norplant, but it is popular across the globe. And then the intrauterine progesterone, the intrauterine progesterone releasing systems. Dynagest, which is a progesterone receptor agonist. We have all been using Dynagest in the form of a combined pill. A lot of combined pills have Dynagest as a progesterone preparation, but Dynagest on its own at a dose of 2 milligrams per day taken for minimum 12 months has been shown in many studies to be a very effective treatment option for endometriosis. It's tolerable too. The side effects are there, but they are minimal. And I like the fact that it is an alternative or an adjunct to surgery. Surgery in endometriosis is not easy, it's not simple, and it's not a be all and end all. It doesn't mean that this woman who has endometriosis has surgery and she's going to be fully cured. That surgery is only a temporary measure, and she might need more and more surgery in future. So if there is a treatment option which could postpone this surgery or which could replace this surgery, then that would be fantastic. And Dynagest seems to do that. There is plenty of evidence. There are so many papers in so many good journals that you find it hard not to be convinced. Personally, I have no link with Dynagest. I have no grants from any drug company which do Dynagest. I'm not a spokesperson for any of them, but having read the literature, I feel convinced that yes, this drug works. I have a lot of patients on Dynagest now, and they're all doing well. They're all symptom free, and some of them are able to conceive later. So to me, this looks like a promising drug which will stay for a long time. And the studies also claim that there are many advantages over COCP. And perhaps what they mean is, at the end of the day, endometriosis is an estrogen dependent disease. We all know that. And COCPs have estrogen in them. And on top of it, COCP will force the woman to have at least 4 to 5 periods a year. While with Dynagest, you might experience irregular bleeding, but what this progesterone receptor agonist is doing is it's lowering the estrogen levels in the endometriosis tissue. And therefore it's going to be far more effective than a COCP, because it's actually making the estrogen levels go very low in the endometriotic tissue. Well, obviously, you don't just need to use Dynagest. I'm sure before Dynagest came, we could have used MPA, we could have used norethisterone, megestrol, dydrogesterone, and we could have used a Mirena coil as well. What's stopping you from putting a Mirena into an endometriosis patient and make her amenorrheic? That's going to help with her endometriosis. But obviously, Mirena can only be used if you're certain this woman doesn't want to get pregnant. And we know that for a very small price, it works for 5 long years. So don't always think Dynagest. If a woman is clear to me that she is not, because even with Dynagest, the woman's not going to get pregnant. But obviously, after 12 months or whatever number of months, you're going to stop Dynagest and ask her to get pregnant. While with Mirena, you wanted to use it for minimum 3, 4, 5 years if possible. So if the woman has finished her family or she says, look, fertility is not an agenda for me at this moment of time, control my periods, control my pain, control my dyspareunia, then I'm going to choose Mirena as my first option, mainly because of cost implications and also the fact that she doesn't need to take a tablet every day, and also the fact that it will stay and work for 5 long years. But if my treatment is meant to be for shorter term and she wants to conceive, then obviously of all these progesterones, I would choose Dynagest. The side effects are going to be there. A lot of people say that they feel bloated, and depression is known side effect, headaches are known side effect with progestogens. And if any of your patients complain of these uncommon side effects, which is the anxiety, cough, diarrhea, fatigue, pain, nausea, irritability, then don't say that they're imagining it. Progesterones do cause them. I just divided the advice based on different college guidelines. ACOG again says NSAIDs and OCP. But what I found interesting in the ACOG guideline, which in fact I find it a bit surprising too, it says 3 months of NSAIDs and COCP, the woman doesn't get better and the pain is still there, then do a laparoscopy. Find out if she has endometriosis, which is fair enough. But it also says that if the woman doesn't want a laparoscopy, give a GnRH analog for 3 months. For a woman, for me to give GnRH analog to somebody, I think a lot of times, one, because it causes all these side effects, two, it is expensive, and three, it is a big thing to convert a woman who is full of hormones into menopausal, even temporary. But ACOG says if you don't want to do laparoscopy, give her GnRH analogs, mind you, for only 3 months. And if she gets better, if the pain's better, then you can diagnose endometriosis based on the fact that the GnRH analog has made her better. That's surprising, but equally interesting. And any COCP is okay. It doesn't have to be a particular brand or a particular progesterone. Any COCP is better. You can do it on a monthly basis, or you can do the tricycling. And what about CA125? Nice guidelines say do not do CA125. Nice guidelines say do an MRI if you're planning surgery. Definitely do an MRI. Nice guidelines say do a laparoscopy. But I personally think it would be a shame to just do a diagnostic laparoscopy to diagnose endometriosis and come out. If you don't have the facility to ablate or do a laser or excise the endometriotic lesions, then do not do that diagnostic laparoscopy. There is no role for diagnostic laparoscopy in endometriosis cases. Even if you don't know it's endometriosis, you're suspecting, always plan treatment with your diagnostic laparoscopy. So do diagnostic laparoscopy plus proceed to treatment. At least do some ablation to that endometriotic lesion. Don't just say she has endometriosis, don't do a staging chart and come out. That would be injustice to the patient. And if you cannot, if you think you not cannot because you cannot, but because you don't have the facilities or you don't have enough assistant help, send it to a place where they do it. But the first attempt should be the good attempt. Don't just cut open the endometrioma, don't just suck, don't just ablate. If you're not excising the cyst wall and not sending it for histology, then take a small biopsy to be sent for histology. Never treat endometriosis without a histological proof, at least later, that it was endometriosis that you treated. And it should always be somebody who has done laparoscopy for endometriosis before. Otherwise, join up with somebody who does it regularly. And when should you follow women? Every woman with a severe endometriosis should be followed. If she has an endometrioma, she needs a follow-up. If she has deep infiltrating endometriosis, she needs a follow-up. What about the GnRH antagonist? Danazol was actually the very first drug which was approved by FDA for endometriosis was danazol. This was used a lot maybe 10, 15 years ago, but these days we have moved to GnRH agonists, which are the Zoladex, leuprolide, etc. And what about the agonists? Agonists are used commonly, and and the guidelines say that use it for 6 months. If you want to use it for more than 6 months, then please give add back HRT, and also please do give calcium and vitamin D to these women who you are continuing for more than 6 months. And any estradiol preparation, 0.65 milligrams with norethindrone, would be a good add back HRT option, or you could give tibolone. If you're giving tibolone, then please give calcium and vitamin D. And intrauterine progesterone, Royal College highly recommends intrauterine progesterone for maintenance therapy after definitive treatment for endometriosis. It works better than the COCP. And what kind of surgery should you do? The Royal College says whatever surgery you do, it's short term, it's not cure. So think million times before you operate on these ladies. Is what you're doing necessary? If you're necessary, are you going to do justice to this woman? Or does she need to be referred somewhere else? And if it is an asymptomatic finding, do not offer any treatment, including do not go ahead and do laparoscopy if she's asymptomatic. And you can excise or you can ablate. Ideally, excision of the cyst wall. If the endometrioma is more than 4 centimeters, you have to remove the cyst wall. Otherwise, it will recur in no time. It will fill up very quickly. If it is less than 4 centimeters and you think you might destroy more ovary by doing the surgery, by doing a cystectomy, because then the whole ovary might end up coming out, aspirate, irrigate, and destroy the cyst wall by laser vaporization or thermal ablation. Hysterectomy can be done for severe endometriosis associated with dyspareunia if the woman's finished her family. But would you do an oophorectomy? If you think about it, all that ectopic tissue will continue to grow if you leave her ovaries behind. But then if you remove the ovaries, this woman's going to become menopausal and all the associated osteoporosis and whatever else happens with menopause. So even for women with extensive endometriosis, if you're doing a hysterectomy, none of the colleges, the RCOG, ACOG, or ESHRE, none of them say take the ovaries out. Though what they need is their ovaries out, it's not recommended. Instead, they would want you to remove the uterus for the pain and then treat the endometriosis with other methods. Only remove ovaries if it's absolutely desperate and if there are large endometriomas and the woman agrees to be menopausal. Okay. Infertility and endometriosis. I'm sure all you fertility specialists out there know this far better than I do. You know if removing that endometrioma is going to help the woman with fertility post-surgery or not. And actually, it says that ablation plus adhesiolysis improves fertility. So if an infertile woman has endometriosis, just do ablate and do adhesiolysis. But if a woman has a lot of endometriosis, and I get a lot of these cases from fertility specialists, huge endometriomas, more than 6, 7 centimeters, 8 to 13 centimeter endometriomas. These ladies get referred to me for surgery by the IVF treatment. They say there's such a large endometrioma, she's not going to do well. I know that my treatment will not help this woman get pregnant spontaneously or will reduce her risk of miscarriage following IVF or anything. All I know is by me removing that large endometrioma from her pelvis, from her periuterine space, I'm going to reduce the hostile environment when she goes for IVF. We tell the woman that this surgery doesn't necessarily improve your pregnancy rates dramatically, but it might make your pregnancy possible. And surgery for an endometrioma more than 4 centimeters is always recommended by all the colleges, but not just because they'll be able to get pregnant after that easily. It is to confirm that this complex, horrible looking cyst on scan is actually endometrioma. And then to improve access to follicles, you want to collect the follicles, you want to make embryos. And with a large endometrioma, you're not able to you'll not be able to do that. So one, it's to confirm. Two, it's to improve your access to follicles. Three, it's to improve the response of ovary to whatever fertility treatment you're going to give her, and to stop this thing from getting bigger and bigger whilst you're stimulating this woman for fertility. And you should also tell the woman that yes, there are so many advantages if you remove your endometrioma, but there's a possibility that you lose your ovary or you will lose your ovarian reserve. I do an AMH before and after surgery because I don't want this woman to blame my surgery for the fall in her AMH. Say you did surgery and then you did the AMH and AMH is too low, and then they say, well, the doctor did your surgery and it's low. Or they could blame me for my surgery if the AMH was fantastic before surgery and now it's drastically fallen. And what does the Royal College say? It says that IUI improves fertility in women with endometriosis, but always combine your IUI with ovarian stimulation, especially in endometriosis patients. And and then you might need to do a high dose stimulation protocols. I'm not into infertility, so I wouldn't be able to tell you much about it. In women with severe endometriosis with infertility, IVF is the appropriate treatment, especially if you think the tubes are compromised or if you think there are added factors like male factor, or generally this woman hasn't responded to fertility treatment better. Don't waste time trying to do IUIs and all sorts of other things. Go for IVF. And uh, treatment, if there's a lot of endometriosis, a lot of adhesions, a lot of everything in the pelvis related to endometriosis, then giving them GnRH agonist for 3 to 6 months before IVF is supposed to help increase the rate of clinical pregnancy. They're not talking about spontaneous pregnancy. You can't give GnRH and then say, go try for yourself. You can do it. I don't think these women can. So after the GnRH, you're supposed to be going ahead with your fertility treatment. Management of endometrioma. And again, the ESHRE guidelines, what do they say? They say that why does endometrioma happen? Endometrioma happens because of invagination of ovarian tissue. It encloses, the tissue grows over the spots of endometriosis. And then there is this coelomic metaplasia theory on the ovary. And then the functional cyst of the ovary turning into endometriosis. That is again another theory. Having an endometrioma obviously reduces your oocyte quality, reduces the number of oocytes you pick up, and therefore laparoscopy and drainage and ablation or excision of the cyst wall is recommended. Excision of lesions is preferential, always removing it in toto. You can't remove it in toto, but you can excise the cyst wall, you can drain and then excise the cyst wall. If it is too big, just an ablation is not going to work. They're going to fill up very quickly. You got to use your instruments. You need a very good laparoscopic surgeon or a robotic surgeon. You need a very good assistant, and more than anything, you need really good graspers. And then you need to peel that cyst wall off the ovary, and often it actually peels off quite well. And don't just drain and coagulate. Always do a cystectomy, especially if it's more than 4 centimeters. And the challenges, obviously, in the treatment of endometriomas. It's not an easy surgery. It can reduce the ovarian reserve. It can, totally mess up with your fertility treatment afterwards. A woman could go into ovarian failure. And the algorithm, there's only one thing I want to point out here, where there are so many arrows which point towards IVF or ICSI. It says infertility workup, and there are many reasons for IVF ICSI. Go ahead with it. Do the ovarian reserve test, and if it's poor ovarian reserve, don't do anything else. Just go for IVF. And then there is severe or moderate to severe endometriosis. Again, don't try for your controlled ovarian stimulation IUI. Go for IVF because you will save a lot of time and money in the meantime. IUI is much cheaper than IVF, but if you've wasted 3 or 4 cycles of IUI and then you anyway go for IVF, you might have as well. So in your endometriosis, patients have a low threshold to go for IVF. And role of IUI and GnRH analogs, the role is only if it is minimal endometriosis. but never just with endometriosis patients have expectant management or IUI alone, because there is a higher chance of failure. There's never like never, but have a high threshold to do ovarian stimulation rather than just IUI. And surgery for endometrioma. And one thing to remember, a lot of referrals come through to surgeons asking for cystectomy, removal of endometrioma prior to IVF. And I believed that if you removed the endometrioma, it improved the pregnancy rate. And actually, I have begun to understand that that's not the case. But what my surgery for endometrioma will do to this lady with endometriosis is improve her pain, improve her symptoms, well, and also improve the accessibility to follicles and reduce a hostile environment in the pelvis when she eventually falls pregnant with IVF. And this is very important when you counsel the woman. She's undergoing a risky surgery, which can cost her a lot. And then you're telling, actually, by removing this, the chances of you falling pregnant successfully are not thoroughly improved. And removal of deep nodules. This again is very, very, very important as a surgeon to know how much to do, when to say no, and when to stop operating on these women. Say I get a woman with infertility awaiting IVF, and then there is a large endometrioma. You will never get a large endometrioma. There is always DIE. They go hand in hand. A woman with severe endometriosis will have a large endometrioma and DIE. This DIE is in between the vagina and rectum. Imagine a woman, a 33-year-old woman who has rectal endometriosis with a hole on the rectum and ending up with a colostomy. That's going to be a nightmare, an absolute nightmare for her and for her future reproductive outcome, and mainly for her morale. What is she going to go out of your hospital thinking? She comes with endometriosis and goes out with a colostomy or a huge rectal complication or peritonitis or something like that. So, if you need to be very careful when you're talking to these ladies before surgery, what is it they want from the surgery? Is this woman in so much of rectal pain that she is not able to pass a motion without being in severe pain? And is she telling you that, look, if you have to take a risk on my rectum, take it, but get rid of this DIE? Or is she telling you that, look, I'm here so I can have a baby very soon by IVF? If her priority is having a baby and she's not debilitated with rectal pain, do not go and remove those surgical nodules completely. Just shave it, remove what you can, but don't compromise the rectum. So because it's not actually going to improve her reproductive outcomes. So when an IVF specialist or you as an IVF doctor want to do endometriosis surgery to improve the IVF outcome, then do a wonderful endometrioma excision, but don't go about shaving things off rectums and taking a risk. So you should be clear that the DIE actually doesn't help with fertility. Moving on to new treatments, because we are 6 o'clock now and I'm nearly finished. All these new treatments sound exciting, but some of them actually make you laugh. You think, where have we come to? We've gone around in circle, and where have we come back to? The angiogenesis inhibitors is one of the treatment options for ovarian cancer, and we think it might help in endometriosis, but it's currently expensive, currently research. Antioxidants, vitamin C and vitamin E. Are we now going to start giving vitamin C and vitamin E for endometriosis after doing all these treatment option discussion? The TNF alpha inhibitors, again, a possibility in future, and again, a good drug which might be tried in future. What about immunomodulators? Again, currently tried in cancer, can be tried in endometriosis too, because cancer and endometriosis behave similarly, the invasive potential and everything. What about these Chinese methods? Are we really now talking about Chinese methods for treatment of endometriosis and green tea? So, when the list is a mix and match of so many different things, you think, which way are we going in our treatment for endometriosis? Stem cell therapy makes sense. Gene therapy makes sense because we now know that endometriosis is associated with a gene defect. So in future, we might hear new names. Most of the names we hear now in cancer treatment, we might start hearing them for endometriosis treatment. But again, look at this. The Cochrane the review says a Chinese herbal medicine will work for endometriosis, and abdominal acupuncture. So we learned how to excise endometriosis. We learned how to safely perform DIE excisions on the rectum, and now we go and do abdominal acupunctures. So why don't we just stick to medicines? Why don't we stop all operating, given it's so complex, and stick to medicine, stick to medication? Well, the problem is high recurrence rates. Once you stop, it comes back. And one of the biggest problems is the medication as such causes contraception. And most of these women do want fertility. And what would you do? And a little bit about surgery. You always will have to do surgery if there is a lot of endometriosis, because medication alone will not work. At one time point, Luna was very popular, where you did uterine nerve ablation, but now it's not thought to be quite so effective. But what might be helpful is presacral neurectomy. And then again, how many of us are very confidently performing presacral neurectomies? That's again something we don't do, but which could be done, which could be learned. And this we already talked about. In spite of ovaries being the mother of endometriosis by providing estrogen, we none of the colleges actually recommend a BSO, say go do a BSO in a younger woman. It's not a recommendation at all. And the final message is surgery involves removal of the endometrioma cyst wall. Otherwise, you haven't done many favors. And if you just ablate, which is what a lot of gynecologists do, you ablate and you think, okay, I've done something, but it's neither good for pain nor is it good for recurrence. Drainage is another option. If you are one of those gynecologists who is comfortable doing a drainage but not removing the cyst wall because that needs some degree of expertise, then do a diagnostic laparoscopy, do a PIC drainage. If it's less than 3 centimeters, 3 to 4 centimeters. If it's more than that, refer her to somebody who is good at it. And even the simple aspiration increases the response to IVF. So don't underestimate the drainage and aspiration, but if possible, always do a cyst excision. And I stop here. Thank you.
Thank you, ma'am. Thank you very much for that detailed and explanatory webinar, ma'am. So hope these participants found this webinar very much useful. And ma'am, yes, ma'am, this severe endometriosis can affect the quality of life in both adolescent and people who are in reproductive age, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. So if there is any queries, then I will read out for you in the comment box,
Sure.
ma'am. Ma'am, I personally have a question like since we are dealing with this menopause, so whether this perimenopause can affect or worsen this endometriosis, ma'am?
I do not think so, because perimenopause is not associated with increased estrogen levels.
Okay, okay, ma'am.
Usually the estrogen levels are low around perimenopause. So, and if someone's reached the age of perimenopause and they've had endometriosis, usually by then they're used to the symptoms as well.
Okay, ma'am. Fine, ma'am.
Yeah.
Ma'am,
So
when it comes to infertility, so when a lady is going for this endometriotic surgery, so how long she should wait for her pregnancy, ma'am? And what will be her impact on this abortion rate, ma'am?
usually, when someone's undergoing surgery for endometriosis and is awaiting fertility treatment, the best thing to do is to actually have some oocytes or embryos frozen, because you don't want to be giving a lot of estrogen stimulation therapy after your treatment for endometriosis, if you know what I mean, because you don't want their endometriosis coming back. So what we suggest is, how much ever, if possible, if it is possible for this woman to have eggs frozen, if follicles are accessible, then have embryos frozen, have the corrective surgery. If more than 50% of the disease has been removed at surgery, then you want them to go for IVF straight away. If, say, still a lot of endometriosis and adhesions, then you want them to have 6 months of GnRH analogs, then they go for fertility treatment. But if, say, the endometriomas are big and the fertility doctor hasn't been able to collect eggs because ovary is distorted, then you remove the endometriomas, Then you give them GnRH analogs for 6 months. Then you send them for controlled ovarian stimulation, where eggs are being where controlled ovarian stimulation and IUI, or you send them for IVF treatment. So depends on how successful the surgery was, and that is why taking lots of pictures and videos and using the staging score is important. Then the fertility doctor, if it's not the same person who has done the operation, can know if the person needs GnRH treatment, or they can straight away go for fertility treatment. But after doing extensive surgery for endometriosis, one thing you should not do is expect this lady to get pregnant naturally, spontaneous conception. And you should say, we'll give you 6 months to a year, you go try on your own, because we did your surgery, you're likely to get pregnant, because that's not going to happen. Any woman with severe endometriosis will never be able to get that complete pelvic anatomy back. And soon after your surgery, you might have caused a lot of adhesions, everything might go stuck back together. You don't know, you don't go back and see. So treat surgery for endometriosis should be followed by GnRH analogs for up to 6 months, then fertility treatment, or straight away fertility treatment. And what is the risk of miscarriage in these women? I think the risk of miscarriage is quite high, or at least higher than women who don't have endometriosis, because endometriosis just creates such hostile environment in the pelvis that we think the risk of miscarriage is higher actually.
Fine, ma'am. Thank you, ma'am. And ma'am, what will be the prevalence of this recurrence, ma'am, recurrence rate? So how
Peak
to manage?
recurrence is very high, very, very, very high, because estrogen, it's an estrogen dependent disease, and you can't block somebody's estrogen off. Even, even if you suppress the ovaries, what's happening to all the estrogen that comes from the body fat? So I don't think endometriosis can ever be cured. This is a disease with an extremely high recurrence potential, and hence you have to think about what maintenance therapy, because without maintenance therapy, I think this woman will end up getting the endometriosis all over again. And the maintenance therapies that we are aware of is one, COCP, two, the progestogens, and three, the progestogen intrauterine, that also can work for 5 long years as a maintenance therapy.
Oh, fine, ma'am. So, ma'am, does it mean that if there is severe endometriosis and there is no symptoms in the women, we don't want to go for any surgery, or normal treatment is enough?
If the woman is asymptomatic, don't treat. Why are you treating her?
Yes.
So if the woman is, if say the woman is asymptomatic and she's not yet had her children, then you might think, okay, she's asymptomatic, but this endometriosis will compromise, then I might want to give her some treatment just so she'll be able to get pregnant. But if I've come across situations, where the woman has quite bad endometriosis, she never had problems conceiving, or she's finished her family, she has no pain, or she has pain and she thinks that pain is normal. Some people think to have pain during periods is normal. Then I don't treat her.
Fine, ma'am. Thank you, ma'am. Ma'am, then I don't find any other questions in the chat box, ma'am. So if you allow us, then we can end the webinar for today, ma'am.
Thank you.
Thank you, ma'am. Thank you very much for your valuable time and your knowledge sharing session with us, ma'am. And I would also like to thank the participants for their active participation. And I would also like to thank my colleagues who made this webinar possible, ma'am. So we are
You,
looking for many more webinars with you, ma'am.
you call it active participation when the participants ask questions.
Yes, ma'am.
So say you thank the inactive
Yeah,
part.
I thank the participants for their active participation. Thank you, ma'am.
Thank you.
Thank you very much, ma'am.